Hello students, as discussed earlier in this part 3 of this video, let's discuss traumatic postpartum hemorrhage, which means there is some trauma which is leading to postpartum hemorrhage. Guys, please concentrate. Procedures like episiotomy or instrumental deliveries like forceps delivery or vacuum. See, they can cause damage to cervix, something like cervical lacerations, vaginal lacerations or perineal tears. Because of this trauma, there is this hemorrhage, okay, traumatic postpartum hemorrhage. So first let's discuss about the perineal tears, tears in the perineum. Why there is a tear in the perineum? For example, now she is primigravida, for the first time she is pregnant and now she is giving the normal vaginal delivery. Now she is have this a very tough perineum, okay, this perineum is not elastic, or this perineum is going to be very tough. What happens? Now when the baby is passing through the vagina, the perineum should be very much laxed, or this perineum should be very much stretchable so that the baby's head will be delivered. What if her perineum is tough, it's not compliant, it's not stretching? Then there will be perineal tears. Now these perineal tears is of so many degrees, for example first degree, second degree, third degree and fourth degree. I have said you why there is a perineal tear. Why? Because non-compliant perineum or tough perineum, or for example there is this macrosomic baby, so much big baby, okay, the head of the baby is so much big, or there is this hydrocephalus. Whenever there is such a big head, there will be so much stretching of the perineal region that can lead to perineal tears, okay. So what are the degrees of the perineal tears? First degree, second degree, third degree and fourth degree. First degree is less severe or milder tear, fourth degree tear are more complicated tears. Please concentrate. In first degree perineal tear, there is tear in the vaginal mucosa or just skin is teared. Okay, it's a very superficial thing. Only vaginal mucosa or the skin is teared. But in second degree, there is this first degree tear, okay, skin or vaginal mucosa, along with now vaginal muscles are also getting teared, okay, first degree along with vaginal muscles are involving in the tear. In the third degree tear, now this was further classified into 3A, 3B, 3C, where 3A means there is the second degree tear, okay, vaginal muscles got teared. Along with that, see anal sphincters, which anal sphincter? External anal sphincter first. Less than 50% of the external anal sphincter got teared. In 3B, there is the second degree tear, also external anal sphincter got involved, but more than 50% of the external anal sphincter got teared. In 3C, second degree tear is there, that is skin, vaginal muscles, along with that external anal sphincter is involved. Along with external anal sphincter, now internal anal sphincter also got teared. Okay, so 3A, 3B, 3C. Now in fourth degree tear, there is rectal mucosa tear also. First degree, that is vaginal mucosa or vaginal skin. Second degree, that is the vaginal muscles also got teared, and in third degree, like external anal sphincter as well as internal anal sphincter also got involved. Now in fourth degree means there is all combined together, first degree, second degree, third degree. Now even rectum, the tear is so much that even rectum is getting affected, or the rectal mucosa got affected, okay. So this is fourth degree tear. Now, how to prevent such perineal tears? Okay, we know that there is this macrosomic head coming out, okay, macrosomic baby or this hydrocephalus baby is coming out, or normal delivery, normal vaginal delivery is happening. Now she is having incomplete perineum. Now to prevent these tears, can we do something? Yes. See, there is this maneuver called as modified Ridgen's maneuver, okay. What exactly is this? Now you know that perineum is going to tear. Now what you can do? with one hand you can support the perineum. So that's what we are doing here. Perineum should be supported manually with the right hand. With one hand you are manually supporting the perineum. Please concentrate here. Now with this hand you are supporting the perineum. You are not allowing the perineum to stretch so much. If it is stretching so much, there will be a tear. You are not allowing it. With other hand, the left hand, what you are doing? You are deflexing the head. Okay, you are assisting the head to deflex, so that you are preventing the tear actually. Okay, if it's happening by its own, there are chances of tears. Okay, the baby is trying to deflex in a very hard manner, for example. You are trying to deflex the head, and with the other hand you are also supporting the perineum. So this is known as modified Ritgen's maneuver. Actually, to prevent to prevent the perineal tears, you can also do episiotomy. Episiotomy means a surgically given incision. Actually, episiotomy is not required in all vaginal deliveries. Okay, WHO doesn't recommend you to perform episiotomy in all cases of normal vaginal delivery, but you can do a modified Ritgen's maneuver to prevent the perineal tear. Now, how to repair these tears? Okay, we know that there is first degree tear, second degree tear, third degree and fourth degree tear. How to manage this? Please concentrate. First degree and second degree tears are managed in the labor ward itself. Okay, during the process of labor, there are these tears, and you are managing first and second degree tears in the labor ward itself. Okay, under local anesthesia, just local anesthesia is enough to repair first and second degree tears. Why? Because first and second degree tears are more superficial tears. See, there is this order how to repair. See, first repair the vaginal mucosa. Okay, first repair the vaginal mucosa with continuous sutures, followed by repair of the vaginal muscles. First vaginal mucosa should be repaired, vaginal muscles should be repaired, and at last the skin should be repaired. So deep to superficial we are trying to repair. First vaginal mucosa, vaginal muscles and vaginal skin should be repaired with the matrix sutures. Vaginal skin with matrix sutures, vaginal muscle should be repaired with interrupted sutures, continuous sutures, interrupted sutures and matrix sutures. So this is how we are going to manage the first and second degree tears in the labor ward itself under just local anesthesia. But third and fourth, okay, third and fourth degree tears, these are more complicated tears. See, they are repaired not in labor ward. You are going to shift the patient to the operation theatre. You are going to repair them under general anesthesia. Okay, now please concentrate. What is the order of repair? First, repair rectal mucosa. See here, in first and second degree tears, first we are repairing the vaginal mucosa, but here we are starting with the repair of rectal mucosa, followed by repair of internal anal sphincter, next external anal sphincter, followed by first and second degree tear. Okay, repair of the first and second degree tear. So what actually I mean by, see, first and second degree tear means again repair vaginal mucosa, vaginal muscles and vaginal skin. So again I am repeating, please concentrate. In third and fourth degree tears, you are going to do the repair under general anesthesia in operation theatre. First you are going to repair rectal mucosa, followed by internal anal sphincter repair, external anal sphincter repair, followed by vaginal mucosa repair, vaginal muscles repair and vaginal skin repair. Okay, this is the order. Okay, you have to remember. Guys, there is one MCQ. Please concentrate here. Rectal mucosa is going to be repaired with continuous suture. This is not the exact MCQ which I am talking about. See, rectal mucosa is going to be repaired with continuous sutures. Internal anal sphincter is going to be repaired by end-to-end anastomosis. Okay, end-to-end anastomosis. You are going to put sutures here. Okay, this is one end of the internal anal sphincter. This is one end of the internal anal sphincter. There is a tear in between them. You are going to repair by end-to-end anastomosis. Okay, for example, if this is the entire sphincter, there is a tear in this area. End-to-end anastomosis. Please concentrate here. How to repair external anal sphincter? See, there are two ways to repair this external anal sphincter. Either you can do end-to-end anastomosis, which is most commonly done, but there is also this overlapping technique, which is best. Guys, this is the MCQ which I am talking about. Best technique for the repair of external anal sphincter is overlapping method. Overlapping means not end to end, overlapping. Okay, one on the other. Okay, one on the other, something like this. Okay, overlapped. Now you are going to put a suture here. Please concentrate here. This is the overlapping technique. This is end to end anastomosis. Most commonly done is end to end, but best is overlapping. Now, please concentrate. Very important MCQ, that when to repair third and fourth degree tears. See, if you can notice these tears, within 24 hours of delivery, you can do immediate repair under general anesthesia in OT. You can shift the female to the OT. You can keep her on general anesthesia. You can do the repair of third and fourth degree tears. But if you have noticed these tears after 24 hours, okay, you have noticed that there are these tears and these tears are bleeding. After 24 hours, now we are not going to treat them now. We are going to wait for 2 weeks. Wait for 2 weeks. Okay, if you are not recognized these tears within the first 24 hours, if you have recognized them after 24 hours, wait for 2 weeks and later treat them. Okay, we have seen how to repair, like first repair the rectal mucosa, internal anal sphincter, external anal sphincter, vaginal mucosa, vaginal muscles, skin. We know this, how to repair, but when to repair is a very important MCQ. Notice in first 24 hours, immediate repair. Notice after 24 hours, wait for 2 weeks. Okay, that's a very important MCQ. First and second degree tears, just after the delivery, you can do the repair of these tears. Now, important point is, see, in a female with third and fourth degree tears, okay, there is this female with third and fourth degree tears. Actually, she should avoid the pregnancy for the next 1 year. Okay, ideally speaking, she should avoid pregnancy for next 1 year or at least 6 months. Okay, so after repair of third and fourth degree tears, pregnancy should be avoided for ideally 1 year or at least 6 months. Okay, we have discussed about the perineal tears. Now let's discuss a few important points about the episiotomy. What exactly is episiotomy? See, episiotomy is a surgical incision. We are going to give it. Okay, if it happens by its own, it's a perineal tear. If you are giving a surgical incision, it is known as episiotomy. Okay, in order to facilitate the delivery of the fetal head, okay, the fetal head is very big or the perineum is like a non-compliant, it is about to undergo tear. Now what you are doing, you are creating an incision so that the baby's head is easily getting delivered. Okay, so episiotomy is a surgical incision to make your vaginal opening large enough for the childbirth. When you are going to give this episiotomy, MCQs, indications of episiotomy, whenever there is a large size fetus, macrosomia, or whenever you are trying to do this instrumental deliveries like forceps or vacuum, then you have to do the episiotomy after coming head in breech. Okay, in breech after coming head, then you have to give an episiotomy. Shoulder dystocia, it's an indication for episiotomy. Non-compliant perineum, yes, this is what we are discussing. Okay, perineum is a non-compliant, it is not stretching. If it is not stretching, it's a risk of perineal tears. Rather than having perineal tear, try to give a surgical incision by yourself. Why? Because it will heal better, the outcome will be better. Okay, now in a phase 2 pubis delivery or suspecting perineal tear, you try to do episiotomy. Rather than having a perineal tear, episiotomy is best because it is having a better healing, better outcome. Now in this slide, please concentrate. There are two types of episiotomies: midline episiotomy mediolateral episiotomy, which means you are going to give incision in the midline. For example, please concentrate here, you are giving the incision in a midline, that is midline episiotomy, or you can give mediolateral incision. Now let's see which one is good and which one is bad. For example, if I am talking about repair, midline incision is going to be very good. Why? Because it heals very easily. Mediolateral incision, it is very difficult to heal. If I am talking about pain, midline incision will be having very minimal pain, and mediolateral incision pain is very much common. Now based on this, what do you think? Midline incision is good or mediolateral incision is good? You are thinking midline incision is good. Why? Because there is less pain, there is a very good healing. But wait, okay, wait. If I am talking about blood loss, please concentrate. Whenever you do a midline episiotomy, blood loss is going to be less. In mediolateral, there is more blood loss. Dyspareunia, okay, after episiotomy, now this female is having this midline episiotomy after the childbirth. Now she is having a normal sexual activity. Now having a midline episiotomy doesn't usually cause pain during sex. Okay, so dyspareunia is a very uncommon, rare. But with mediolateral episiotomy, occasionally there can be pain during sex. Extension, guys, this is a very important MCQ. Just for this one MCQ, I am discussing the entire topic of episiotomy. Guys, extension. What exactly I mean by extension? Please concentrate here. I have given a surgical incision in a midline. See, from here till here, I have given a surgical incision in order to facilitate the delivery of the head of the baby. Delivery happened, everything is okay. I have kept sutures, everything is fine now. But after some time, see, this incision, this surgical incision, it can extend and it can involve the anus. It can involve the anal sphincters. Whenever there is extension of midline incision to the anal sphincters, it can lead to fecal incontinence. Okay, this is a very important point. If extends, please concentrate here. What is the disadvantage of midline incision? This is a very bad thing about the midline incision. If extends, it involves the anal sphincter and can lead to fecal incontinence. But please concentrate, extension is uncommon with the mediolateral. Though it is going to be associated with little bit pain, it is associated with dyspareunia, more blood loss, but there is no extension to anal sphincters. Whenever the anal sphincters are not getting involved, there is no risk of fetal incontinence. Okay, so that's a very important point. But the disadvantage with the mediolateral incision is more muscles need to be cut. Okay, as you are going laterally, more muscles are coming in the way. But please concentrate, midline incision is considered as a first degree tear, but mediolateral incision is considered as a second degree tear. Though mediolateral incision is a second degree tear, it is best because there is no extension, there is no involvement of anal sphincters, there is no risk of fecal incontinence. So if you are asking which is best, midline versus mediolateral, mediolateral is best. Okay, mediolateral episiotomy is best. Okay, now let's talk a few important points about hematoma. There is this bleeding happening and it is going to clot and form a hematoma. Okay, now what is the most common site of pelvic hematoma? The most common site is vulva. Okay, so vulval hematoma is the most common pelvic hematoma. What is the most common artery to form a vulval hematoma? Vulva is getting supplied by, or vulva is also known as pudendum. Pudendum is getting its blood supply from pudendal artery. So most common artery to form vulval hematoma is pudendal artery. Now what is the most common artery to form vaginal hematoma? Okay, you can have this female because of this so much amount of bleeding, now she can have either vulval hematoma or vaginal hematoma. The most common artery forming vaginal hematoma is uterine artery. Okay, uterine artery. See here there is this vaginal hematoma, so not vaginal hematoma, vulval hematoma in both the cases. Now what is the most common symptom? The most common symptom is going to be pain and there is difficulty in the passage of urine. On physical examination what you can see is the mass, okay, bluish color mass, okay, because of this congestion of the blood. What you can see is the bluish colored swelling. How to manage? See, usually we are going to do the conservative management. Conservative management means, now if she is having pain, try to reduce the pain by giving analgesics. And also what we can do, like we can also try to use the ice packs. So the conservative management is ice packing with the analgesics. This is a conservative management. But sometimes you have to involve yourself in surgery, okay, surgical management of hematoma. What are the indications first? When to do the surgery? If she is having so much amount of pain, excruciating pain, because of so much amount of active bleeding, okay, now there is this active bleeding, so much amount of active bleeding, that's causing instability in the patient. A patient vitals are now getting unstable, patient is having excruciating pain, or the size of the hematoma is increasing. The size of the hematoma increasing means there is this active bleeding. Now what to do? In surgical management includes drain the hematoma. If there is this active draining vessel, close it. Okay, this is the surgical management. Okay, draining the hematoma. Okay, now see here you can see that the vulvar hematoma is being drained. After this, let's talk about uterine rupture. Okay, during the normal vaginal delivery, there is a chance that because of increase intrauterine pressure, there is rupture of uterus, and such rupture of uterus can lead to uterine atonicity, that can cause atonic postpartum hemorrhage, or directly this rupture of uterus can bleed and can lead to traumatic postpartum hemorrhage. Now let's see some important direct single liners. Most common cause of uterine rupture is, most common cause, previous cesarean section. Okay, previously she is having cesarean section, there is this scar tissue which is not strong enough to hold the intrauterine pressure, so that there can be rupture in that area, bleeding leading to postpartum hemorrhage. Okay, so most common cause of uterine rupture is previous C-section, and that scar is a more liable point for the rupture. Most common cause of uterine rupture in a non-scarred uterus. There is no previous C-section. Now what are the causes of intrauterine rupture? Not intrauterine rupture. What are the causes of uterine rupture? Prolonged labor or obstructed labor, to be specific, obstructed labor. Okay, uterus is contracting but baby got stuck. Now uterus is trying to contract as hard as possible. So intrauterine pressure will increase, because of that uterus may rupture. So obstructed labor or having some Mullerian abnormalities like uniconveate uterus, uterus diidal phase, biconveate uterus. So having a Mullerian abnormality or a grand multipara. Grand multipara means now she is having such a uterus which is more weaker. Okay, I can say something like that. Okay, now her uterus got contracted for the last 5 times. Now her uterine musculature got so much stretched and the uterine wall is more weaker. So it can rupture very easily. Okay, so grand multipara or obstructed labor or Mullerian abnormalities, all of them are also causes of uterine rupture in a non-scar uterus. What is the sign of impending rupture? Okay, impending rupture. What exactly I mean by? See, rupture not happened so far, but rupture going to happen. What are the signs? If rupture is going to happen, if you look at the fetal heart rate, there will be fetal tachycardia. Okay, the signs of impending rupture is fetal tachycardia. But once there is rupture, okay, once there is rupture, now there will be fetal bradycardia. This is the MCQ which will be asked in the exam. Impending rupture, fetal tachycardia. Already rupture, there is fetal bradycardia with maternal tachycardia. Okay, now mother is going to have tachycardia. As there is so much amount of blood loss, there can be maternal hypotension, and you can feel the parts of the fetus superficially. Why? Because the uterus got ruptured. Now you can feel the fetal parts. Okay, the fetal head might be coming out of that ruptured uterus, or the fetal legs or fetal hands will be coming out of that, so that you can feel those parts. Okay. Now, there is this fresh blood coming out of the vagina and loss of uterine contractions. Once the uterus is ruptured, it is not going to contract. Now, what is the management of the uterine rupture? How you are going to manage it? See, if you feel that there is impending rupture, or if you feel that uterus is going to rupture, for example, there is this fetal tachycardia. Okay, the sign of impending rupture is fetal tachycardia. You are suspecting that uterus is going to rupture. Now, what to do? Do immediate C-section. Okay, immediate C-section is the management for impending rupture. But once if there is already rupture, what to do? Now, perform laparotomy and repair the uterus. Okay, so if there is already rupture, what you can do is laparotomy and repair the uterus. Okay, so this is the management of a uterine rupture. Like we have discussed some traumatic causes of postpartum hemorrhage and some important topics which are needed for your exam. Hope the video is helpful. Thank you. We have completed all three parts of the postpartum hemorrhage. Again, first part, management of third stage of labor, that is active management of third stage of labor. In second part, we have seen management of postpartum hemorrhage, and in third part we have discussed about the traumatic causes of postpartum hemorrhage. Thank you.